that's really what this is all about, volunteering. So, we're going to get started here. I'm going to introduce Kristi Wick, who really, I just asked her, Kristi, what do you want me to tell? Kristi's curriculum vitae goes on for pages. Thank you. Kristi is a nurse and the professor of gerontology, and she has an incredible program at the University of Tennessee, Chattanooga. I go back and forth to North Carolina, so I get lost. Any case, she's going to introduce herself a little bit, but she does an amazing set of things around involving communities in the care of their elderly. So I'm going to turn the program over to her, and I know she has time for questions, but I hope that this is sort of our keynote of what we're hoping to do, is to get the community engaged with our elderly. So, Kristi, and welcome to the North Family.
Thank you. Thank you all for having me. I see how far I can get here so I can see your faces. I am thrilled to be here. I'm from Chattanooga. I am originally from Florida. I was born and raised in Ocala, but have been in Chattanooga since my first was born, so 23 years. So I feel like that's pretty much home for us. We did live in Upper East Tennessee for a little while as well. I am, again, super excited to be here. And what I'm most excited about is the diversity of this group and all the different things that you all do, both in your professional roles at work, but also I'm sure in your home and in your volunteer positions in your community as well. My job here is to kind of kick things off for you today. You have some great speakers planned and some great content. I hope that you will learn a lot. I'm just kind of hopefully going to get your wheels turning. And so please feel free to get up and move around. I have 4 boys. I'm used to like nobody paying attention to me when I talk, so I'm totally good with all that. And feel free to ask questions or interrupt me. I really am going to ask a couple times for your input as well, because honestly, you all are the experts in the room. My job is just to kind of help you start bringing some of this into the conversation so that you can advance the care of older adults. Now, a lot of people use different terms. You'll hear, what are some of the terms you hear people called when you're older in age? Help me out. Senior. Granny. Elderly. That's right. So we're working very hard to reframe some of this language. We like to say older adults just because it's not putting a connotation to a word that makes a person feel like they're at the end of their life, or they're less than, or they're not capable of doing things that other adults are not able to do. So like younger adults or middle-aged adults, we tend to go with older adults. And so always the big elephant in the room is, well, what do you mean by old? And everybody's thinking, am I old or am I young? What am I? So really, old is a connotation of your function, how you feel. When I see someone in the clinic, I promised Dr. Levin I'd say a little bit about myself. I'm a nurse practitioner. I practiced at the Alexian PACE program in Chattanooga, so a daycare center. Fabulous interprofessional network, very complex older adult care. Practiced there for about 5 years, and then I went to private practice. So I did kind of the opposite and went to see what the community was about without all the supports of an interprofessional team. And after about 5 years of doing that, the opportunity came to return to the university, but I was really pretty burnt out with the same type issues that were occurring over and over again, and it really had nothing to do with medicine. I like to say that when we take care of someone and we help them become healthy or have a better quality of life, it's really like giving someone a prescription is like 5% of that maybe. Making sure people get to the doctor is, a little piece of that. The real medicine, the real change comes with all of you in the way that we interact day to day and how we help people preserve their function. So when I was in clinic, the date of birth only mattered to me when I made sure you were who you say you were, right? Or that I had the right chart in front of me. Other than that, and some screening, preventative things that I need to do in my head based on age isn't a factor. So we really don't try and categorize people as old. I would have I had a patient who ran a marathon at 84, and then I had a 40-year-old who was completely homebound and unable to do any of his activities of daily living. So to me, it's more about function and quality of life, right? So there's not a particular age to it. There'll be a little caveat to that in a minute, but I had a little video to get us started. If it works, if it doesn't, it's okay. But this is my favorite AARP video, and it's quick, it's not long. Oh no, will it let you hit play? It might not. There we go. Hopefully you can hear it. We'll see. It may just take a minute to load. And maybe not. Okay, we'll keep going, that's okay. So basically in this video, it's a great one to look up later. It's basically the same thing, what is old. And they bring in a group of young adults, teenagers, 20-year-olds, 30-year-olds, and they say, what is old to you? And they say 30 and 40 and 45 and 55. And then they say, they pair them up with people who are 55, 65, 75, 85. And they teach each other an activity. So there's someone that does yoga, and it's hysterical because the woman who's teaching the yoga, the young man who's super looks strong, can't do a lick of it. And so they really learn an important lesson about function and how age really doesn't define who a person is and what they're able to do. So there's a model of successful aging, and this is really part of our change in terminology. Our goal is that people age successfully. We don't want to look at the last, 20, 30 years of someone's life as a downer and a bummer. We want to live successfully, right? We want to enjoy it. Life's not over. So our goal is to make sure that we're healthy. What does health mean to all of you? If you defined health, what would that mean?
I feel good.
Yeah. What did you say?
I feel good.
I feel good. And mental, physical, social. Great. So health is those things. It's all encompassing. And it's also the absence of disease, right? So trying to stay as healthy as possible, less disease as possible. Function, of course, is that ability to get around. Are you able to get up? Were you able to drive yourself here? Are you able to brush your teeth in the morning, get your medicines, take your medicines, keep track of your medicines? All those things come into that group of function. And then activity. We know that activity is so important. That's why we're here in this building, right? Activity is a huge piece of our psyche, of our ability to maintain our mental health, of our ability to maintain our function. We certainly saw during COVID that staying isolated and being away from people and away from activity was detrimental to those who were in skilled nursing facilities or assisted living, and even at home in the community. Social isolation is devastating to all of us, not just older adults. So activity is hugely important. There's a lot of research around that, especially now. So the model of successful aging is bringing those three together, keeping someone as well as possible, as functional as possible, and as active as possible. Any questions on that? Okay. So the challenges that we have are our population growth. Dr. Levin mentioned earlier, our group of older adults, and this is kind of the caveat, for purposes of research and data and giving you statistics, a lot of that data starts at age 65, some of it age 60. And the reason for that 65 is because that's the Medicare age. And CMS, by and large, has a huge pot of data. Less so than they did a few years ago because of all the Medicare Advantage plans. Those now are kind of taking some data on their own. But the point is, the reason that we talk about 65 plus is because of that Medicare age and that data that's associated with everything past that. Now, senior centers, and I serve on the Tennessee Commission on Aging and Disability. We're able to get some data through Area Agency for Aging and Disability across the state. So some of that data is going to be 60 plus. So when we're talking about population growth, we know that that group, that 65 plus, in the next 5 years to 10 years is going to balloon another 20 to 25%, and that's, if you look at every single county, those are the projections. Life expectancy actually continues to increase. As we have better health tools and better radiology and better treatments, people live longer. And I used to say, it seems like those of us who have really healthy bodies, who are physically healthy, lose some of that mental capacity, right? Whereas people with chronic disease may not live as long, but their mind is intact. So we want people to live as long as possible, but to preserve all of both their mental and physical capabilities. Chronic disease is bad. It's bad across the nation. It's really bad in Tennessee. We'll get into some of that in a minute. And then the provider crisis. There's not enough of you guys, right? Even our caregivers. We are working very hard. There are people at the state level working very hard trying to figure out how to train and recruit more people to provide some of the care that you all provide day in and day out. So this is from the state profile, which is published by the Tennessee Commission on Aging and Disability. I put a red circle around it because it's age 60 plus. But this was the 2022 publication, which means it was from 2021 data from the Department of Health at the state level. These are the residents in Monroe County over age 60 was 14,300, projected to be 16,800 by 2030, and then 17,000 by 2032. And the point of all this is how we're going to care for everyone, how we're going to make sure everybody has transportation, how we're going to make sure everybody is successfully aging and enjoying life. So the risk factors for death, the risk factors for functional decline, and institutionalization, so going to an assisted living or nursing home, are across the board the same. And older age is one. That's something we can't change. Literally, it's the one thing we all have in common. We are all aging as we sit here. Cognitive impairment and memory loss is a huge threat to people being able to live on their own. Functional dependence, not being able to do your own activities of daily living. Malnutrition, whether it's from an illness or because of lack of access to food or whatever the case may be, that's a huge threat to someone being able to stay in their home. And then frailty, which is a conglomeration of different things, but basically along those same lines as malnutrition. And so our national healthy aging strategy is really to promote health, to prevent poor health outcomes. We do that through those same things we talked about in that model of successful aging. Mental health, managing chronic conditions with our physical health, memory, and then this is social engagement on the far end here, so making sure that people are doing their activities. So you see consistently across the board that same thread of commonality. Okay, so physical health. So when you think about chronic conditions for adults, which ones come up as in your mind as probably the most common or prevalent? Falls. Mm-hmm. Heart failure and diabetes. COPD, right? Yeah, so those are some of the big ones. So this is where, I think her name was Teresa, but the state of complete, this is the World Health Organization's definition, state of complete physical, mental, and social well-being is the definition of good health. So you're not going to be able to see all these, and that's okay. A lot of it's to help me remember some of these numbers, but this is a CDC infographic talking about chronic disease in America, and this is actually young adults, so our 18 to 64 age range. So 6 in 10 have at least one chronic disease. 4 in 10 have at least 2 or more. So these are 20 and 30-year-olds who are already experiencing some of these issues. The biggest ones that some of you mentioned, heart disease, cancer, COPD, stroke. We're seeing Alzheimer's disease and other dementias diagnosed earlier and earlier and earlier. And then chronic kidney disease. And so these lifestyle factors, which is really one of the main reasons I use this slide, are that thread that brings all that together, and we'll see as we continue to go through today. Tobacco use, poor nutrition, inactivity, and then alcohol use. Those things are really what we see nationwide as the precursor to some of these diseases. Older adults. So, as a general rule, this is now National Council on Aging, so it's across the United States. 80% have at least one condition, chronic condition. 68% have 2 or more. What do you think the percentage is in Monroe County for 4 or more chronic conditions in older adults? Yeah. The state thinks it's about 40%, between 40 and 45. It may be higher. That's a whole nother story about that, but the point is we all struggle with most of these things, right? Or we know someone that does. High blood pressure, high cholesterol, diabetes, heart failure, kidney disease, depression, and then of course our dementias. So again, we just see that thread from when we're younger and then we're progressing to older age where we see some of those other things compounding, building up on each other. Yes, ma'am?
And then the thing that adds on that is as a provider, if we treat these things, the 11th circle should be polypharmacy.
Polypharmacy, absolutely, 100%. Look at there. We're going to talk about polypharmacy. So, we're tied into it all, yep. So, as a result, we have trouble with falls, right? As people become less active, less able to get up and around. Maybe they need home modifications. Maybe there's too much stuff in their house, but falls become an issue. Maybe they have poor judgment. But falls are a huge reason people go to the emergency room. They're a huge cause of early entry into assisted living, nursing homes. You guys all know that. They keep firefighters busy. In Chattanooga, falls are awful. Driving is an issue. We have to maintain our ability to drive and drive safely. Taking away the keys from someone is probably the worst thing I ever have to do as a practitioner. It takes away independence. It kind of starts this spiral of depression. It's rough, but it's something that has to be addressed. As Dr. Levin just mentioned, polypharmacy, pouring on all these pills. That is a huge problem. And I would say as a second piece of that is seeing a bunch of different doctors and specialists. They're needed. There's a time and place for them all. But we as professionals, those of you who are in the professional business, we have a responsibility to communicate. And if you're in home health or one of those others, it may require communicating with the different specialists and being the quarterback. You know, if the primary care person's not doing it, then it may be somewhere where you have to jump in as well. But that's probably one of my biggest pet peeves. Insomnia is a huge problem, or what's perceived to be insomnia. Incontinence, you guys know, especially both in the community and in facilities in your homes, incontinence is tough. It's a life changer for quality of life. It can be expensive for personal products. A lot of times it can be treated. So it's those of us who are on the professional side paying attention to some of those cues, and maybe it's a medication that's causing it. I have a long story, it's not long, but of a patient who, she lived in a group home and she got a hold of some green tea. And she was younger, but all of a sudden she became incontinent at night. She was wetting her bed. And so this ended up in this huge thing. And in the end, when we stopped the green tea, the problems went away. So part of what we do as health professionals is serve as private investigators too, right? So Chronic pain is an issue. As you all know, pain is no fun. We all have it, but those who really struggle with it can really lose some of their function and quality of life. I'm sorry, you guys probably can see. So from the physical standpoint, the things that we can do are to make sure everybody's getting the proper screening that they need for mammograms if they're needed, and colonoscopies, and making sure people get the vaccines that they need. You guys in the health department are adept at all that information. But it's not just about making sure that people get them, it's about changing some of the perceptions and thoughts and doing some of the education in the community. So every time we have an interaction with somebody, whether it's at church or at the courthouse or at the grocery store, we have to be mindful of the things that help keep us healthy. And a big piece of that, especially for older adults, is planning. And we'll talk a little bit about that in a minute. Does anybody have any questions on any of that? I know I went through it fast, but I feel like it's kind of known information. Okay, mental health. The thing I'm going to say about mental health is that, as I mentioned before, social isolation is one of the really key things that causes spiral in people. There are lots of programs, nonprofits, churches, senior centers that work towards reducing some of that isolation. Isolation typically leads to depression. It can also lead to more health challenges and staying well, because people begin choosing not to take care of themselves sometimes. So social isolation is a big thing that we really try our best to make sure that we're a community that has transportation to get people places, or that we have churches who are willing to go visit, people who are willing to take food and activities. This is a picture of during COVID, our adult housing in Chattanooga. We went to the library and got a bunch of books in the stacks they were kind of going to give away, and then activities and different things, and just pass them out door to door. And I know a lot of communities and your organizations did similar things, but it makes a huge difference when people have something to do. The one on the right is we did a door decorating contest, and the staff, we did it for both the residents, but then also offered some incentives for staff at our skilled nursing facility to help them, and it became part of the activity that they did for occupational therapy and all, and having residents decorate their door, and they got to pick, but we provided bags of supplies so they could kind of make their own stuff, and they loved it. And then the staff would judge, so there was a big judging contest. And so these things are all just different ideas of ways that we can help combat some of that social isolation. Oh, clicker remains on. See if it'll click for you. This is small. It's not meant for you to necessarily read or take all that in. It's meant as an example. These are categories of mental health disorders. There are a lot of mental health disorders. Underneath each of these bullet points is lists and lists of different mental health diagnoses. Public health officials are working really hard to help call attention to, provide education for, make sure people get treatment for the different types of mental illness. Depression in older adults is huge. So it's really huge in all ages, but it's often overlooked in older adults because there's the connotation of, well, you're just getting older, it's part of life, that stinks, life has changed. And especially revolving around grief and losing significant others, or losing children, or losing parents. There is very few resources for helping get older adults to some counseling and things like that. But a lot of times that's where our faith communities come in, our senior centers. Having some interaction with people can help as well. We have a mental health expert who kind of travels with us, and she does a huge piece on listening and active listening. And really, it's pretty basic. I don't feel qualified to deal with a crisis or mental health disorder, but by following simple steps, we can all really provide some of that active listening to help people kind of come out of their crisis and get some help if there's an issue. So mental health is important. So dementia. Who can tell me the types of dementia? Some different types. Vascular, Lewy body, yeah. Yeah. So, as you all know, the dementia word is an umbrella term for memory loss. And it really gets confusing because a lot of data comes out that talks about Alzheimer's. We have the Alzheimer's Association, Alzheimer's Tennessee. So it's very confusing for people, patients, community members, legislatures, to understand the difference that there's more than just Alzheimer's disease or that there are different types. And you say, well, why does it really matter? It's memory loss. Well, the reason is because, as you all know, they act differently, right? Lewy body dementia is its own bird. It's its own bad bird, right? So knowing whether someone is, to the best of our ability, has Alzheimer's disease versus a Lewy body or a vascular or maybe a mix, it helps us plan their care. It helps you all plan their activities. It helps you all get their family involved so that they can start planning for the care that this person's going to need. So 10, 15 years ago, we didn't have the ability to tell the difference. We didn't really know that we knew there were different types, but we weren't really sure what the difference was. Now with technology, we're able to tell a little bit more. We can see through PET scans some of the plaques that can build up in the brain. There's been medication in the news lately. So we've made some progress, and the important thing to know is that by knowing what type a person has, it helps us plan a little bit better. Most of you are probably familiar with the facts and figures that the Alzheimer's Association puts out. It's like, I love data, I think I said this before, so it's like my most joyful part of my day or my year when this comes out and the information from the Department of Health comes out, because I want to see what we're doing. And you have to take the statistics with a grain of salt. This is the best information that we have, and it's still poor information. We don't really have any idea how many people have memory impairment. To be able to be included in these statistics, you have to either have had a hospitalization with that diagnosis, a diagnosis from a physician that's gone through on a claim form, or interacted with maybe an area agency or some other public nonprofit organization that's collected some of that data. How many people do you know that have never been to the hospital for dementia, or never been to an area agency on aging or a senior center? We don't know, but these statistics are staggering enough that it's concerning, right? We know that we have to do something. So this is a great place to look for information, and of course they put out the state statistics as well with that. So this is a profile, a county profile that the Tennessee Department of Health publishes, and honestly it was published in 2020, I believe. So these are going to be like your 2017, 2018, 2019 statistics. Risk factors for dementia are the same across the United States in all our research. Age is an issue. We know gender is an issue. Family history and genetics. Having Down syndrome puts you at higher risk for developing dementia. Traumatic head injuries. We see this with football players and athletes or people that were in car wrecks. Traumatic head injuries can increase your risk, as well as high cholesterol and high blood pressure. We'll talk a little bit about healthy heart, healthy brain. All the things that we do for our heart apply to our brain too. So this is Monroe County. It's a little hard to see. At this time, they said the population overall was 46,357. The percent of your population at 65 and older was 21%. They list a couple different demographics, but they also put in here access to exercise, which they said was 75%, which I thought was pretty high. And physical inactivity is 31%. The prevalence of Alzheimer's disease at this point, and again, you have to think about which type dementia and all that, was 11%. The next ones are COPD at 14%, diabetes at 30%, hypertension at 63%, which is a big one, because hypertension leads to what? Stroke, kidney disease, all sorts of bad stuff. So 63% is a big number.
Wow.
In the state ranking, Alzheimer's disease was the 7th leading cause of death. So, or I guess in the county. They went to each county and looked at different causes of death and then ranked those. So for whatever the record showed at that time, Alzheimer's disease was number 7. Again, does that mean it was Lewy body and all that thing? That's very vague. So for diagnosis, as most of y'all know, we always want to start with a physical exam, blood work, imaging. Some people choose to do genetic testing. It's not necessarily readily available. Lumbar puncture is a next step if there's really an issue and a neurologist wants to go down that path. Cognitive testing, and then neurocognitive testing, which is a kind of an elevated, with some other psychological studies in there. This is important specifically for those who are young, and you're really trying to figure out what's going on and what's causing their symptoms. Often we'll see a lot of alcohol involved when we're really having a hard time getting say a 45-year-old male diagnosed. Something's going on with mood, we can't really figure it out. And then we kind of piece out some alcohol use there. But there are certainly other things. So a lot of people don't want a diagnosis. A lot of people say, I don't want to know if I have dementia. I have no desire to know. That's a terrible diagnosis. There's no cure for it. Why would I want to know? I just want to live my life and be happy. And part of our job is to provide the education to remove some of that stigma and that fear. People with dementia can live a very long time with a very productive life. The diagnosis itself does not mean that tomorrow they're not going to be able to function. So it's part of the work that we're doing, trying to remove some of that stigma and provide that education. The benefits of getting diagnosed help with planning. They help you bring in some modifications if you need it. Perhaps you need a little bit of help with your finances, but everything else is going fine. It's really important. It helps us address safety in the home, make sure people are safe in the home. Helps you establish those care partners. A lot of people might move to a different place in the country to be nearer to their children, or their children might move there, but some conversations can happen around that. Also allows you to take control of your health. It may be, especially now with some of the new medicines that are on the horizon, that we're able to get more activity and do some more crossword puzzles and engage our brain and get active. And perhaps some of those things will stall out a little bit. Two pieces, legal planning is huge, and it's huge for everybody in this room. You do not need to be an older adult to do your legal planning. I tell my 20-year-old kids, you need to be thinking about what your wishes are. Advanced care plans are incredibly important. Your healthcare power of attorney, your power of attorney for your finances, your wills, all those things are super important, but we have got to help provide that education. And having a diagnosis like this is no different than a diagnosis of diabetes or a stroke. People need to be able to plan, and so any opportunity we have to encourage that is important. The last thing I'll say is it's the benefit of research. Just like children in the United States, we have rules that people should be able to have the opportunity to consent to research, to say, yes, I want to do that. Research in children is hard because they don't have that ability to make that decision. It's typically their parents. The same thing happens with older adults with dementia, because if they don't have that capacity to make decisions for themselves, it's really kind of, should we do that research or not? Is that really right? By getting an early diagnosis, it helps us a great deal research-wise. We can look at radiology, whether it's MRIs or PET scans. It doesn't mean that it helps us with drugs. It does. But one of the major things that we're researching right now is caregivers and things that help caregivers. And so we need people that are caregivers or people with dementia or people with early dementia to find out what would help them. There are lots of apps. We're working on, UT Knoxville is working on robots that go in and help provide songs and time slips type information, prompting for stories and things like that. That's all research, right? But because of the way that we do research in the United States, we need some of those diagnoses to be able to say, this really helps this group or this really doesn't. So it's important that we try and get that information out there and that we try and encourage people to participate, because not everything's about a vaccine or a medication. There are a lot of things that we do research on that are in the community. These are just a couple of examples. Most of you guys don't know, but the different cognitive assessments that are done or should be done. As part of the Medicare Wellness Exam, people should be screened every year for with at least a mini cog, which is the 3 questions and generally a clock. Only 16% last statistic I saw were even offered the opportunity to have that screening. So we need to do a better job as healthcare providers to make sure that that's done. Treatments, there's no cure, as you all know. To Dr. Levin's point, we have some medications. We try and help caregivers with medications for sleep, medications for behaviors. But the good news is there are a lot of alternative treatments, and part of that research is getting that information out there as well. Working on, just like with babies, working on scheduling, working on activities, working on important conversations, but providing that schedule and routine is huge, and often we can avoid medications. We do how many of you are familiar with the virtual dementia tour? Probably most of you, some of you, yeah. So we do that with all our nursing students, and we had a nurse practitioner student go through it, and these guys are back for like a post degree. They've already been practicing in the hospital, so they pretty much know everything, right? Like there's nothing we can teach them. But we put them through the virtual dementia tour, and the next day I got a call from one of the male students who had been a nurse for a really long time, and he said, I just want to tell you that was a total game changer. And he said, I didn't even realize it till I was on my shift last night, and I had a patient who had dementia. It was a man, and he was really agitated with going to bed. And he said, rather than calling the on-call doctor and using an order for Ativan or one of the other mood stabilizers for sleep, he said, I called his wife, and I said, is there anything that helps him settle down? She goes, oh, sure, just put him on the phone, and it was a song or something that she sings. And he settled down and went off to sleep. And he said, I never would have thought of that had I not been through that experience, thinking about the ringing that they might hear in their ears or the noises and things like that. But so just having an experience like that can help frame and change the trajectory of how we're treating people and increasing that quality of life. It's important. This is only here to show you that the NIH has phenomenal resources, lots of color page diagrams that go through the different types of dementia as well as the symptoms, some of the things that you can do, diagnoses, next steps if you're diagnosed. They're all free. You can order 100, but it's a great resource, or you can just download them. So I highly recommend even for COPD and different things, there's a great wealth of information on the NIH's website. Our office is full of these. And this is just a blown up example of the different symptoms at each stage of Alzheimer's disease. Again, the education, knowledge is power, and being able to explain to caregivers or professionals what to expect in each stage helps them plan, but it also helps them understand that this is part of the disease progression, right? So getting that knowledge out is super important. We know that, we'll talk about workforce at the end, but part of workforce is being able to hire and retain good nurses and CNAs and activities directors and social workers. Well, how many of you like going into a room where somebody's really upset and you really have nothing to offer them? right? I'm knocking on a door and I know that what that person's gonna tell me, I have nothing to help them with. It's terrible. So we wanna give people the tools, give our caregivers, give our, both in the home, in the community, our faith organizations, we wanna give people the tools to help, because it boosts the confidence. It gives people strategies so that they get through their day. We know that people stay longer in their jobs when they have the tools to help people, right? Last thing on this, the Healthy Brain Initiative is also a massive initiative by the CDC. I know you guys have worked some with that too in this county through Summitt and Alzheimer's Tennessee maybe. Lots of information and resources at the CDC's website on the healthy brain. A lot of it about risk reduction, different programs, infographics, lots of things, videos, social media stuff, lots of stuff there. So to wrap up dementia, stigma and fear. That's our job, right? Is to get rid of that stigma and get rid of the fear so that we can have conversations and we can help people have that time of successful aging. And help caregivers as well. Any questions on dementia?
Yes. One thing that I felt was missing, and that's partly from my background because I worked with deaf and hard of hearing for over 40 years, the impact of hearing loss
Yes.
on this whole situation.
Yes.
My sister, who now has a profound and severe hearing loss, she's in her 60s, and if I don't go and talk to her face to face, even when I talk to her face to face, she can misunderstand. She has hearing aids.
Mm-hmm.
When she was working, the post office sent her for Alzheimer's. They thought she had Alzheimer's because she wasn't responding to that whole thing. The impact of hearing loss, I'm questioning because I didn't see it anywhere there.
And I either missed it or it's coming up, but I'm glad you brought it up because I definitely meant to talk about it. In fact, I got an email, some of you may too, from the big international Alzheimer's convention is going on somewhere across the ocean. And I got an email, some of the studies on the first day showed the incredible impact that hearing loss has on both quality of life, on dementia. Did you guys know that in like the 50 to 50-year-old age group for men, hearing loss and cardiac disease go hand in hand? It's bizarre. We don't really know why, but we know that there are so many things that are impacted by hearing and vision. I have my theories, but it's really, really important that we make sure when we're doing our health screenings and our prevention that people are getting their hearing exams and they're getting their eye exams. Now, the caveat to that is, do you send somebody to do something and you know they can't afford a hearing aid or they can't afford glasses? That's a huge problem that we have for all age groups. Lots of nonprofits are helping with that now. There are lots of changes with hearing aids. Even my father was really, really stubborn. He finally went and got kind of an over-the-counter hearing aid and then said, well, life's a little different when you can hear, and so he finally went and got tested. But so being cognizant of the fact if it's a family member or someone in the community or a church or a patient, whatever, it's great to get that screening, but we have to think about what we're going to do after that, right? We have to help them get that assistance if they need it. It's a great point. Thank you very much. Huge in social isolation, too. Hearing loss is horrific for both vision and hearing loss. So caregiving. Am I okay on time?
You're good. You're about 35 minutes.
Oh,
okay.
Sorry, y'all.
And you got community all of it.
Yeah. Okay, so caregiving. So this is, I don't know how this can't be a favorite if you're a caregiver or if you work with caregivers, but Rosalind Carter, First Lady Rosalind Carter, there are only 4 kinds of people in the world. Those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. And it's really true. When we talk about caregiving, there's different definitions. So you've got your formal caregivers, those of you who work in your profession, taking care of people. You've got, even just in the profession, people who work in skilled nursing facilities or assisted living or acute care in the hospital or the emergency room. Nurses, social workers, chaplains, all those people that work in the community. all different kinds of formal caregivers. I would also lump in our nonprofit and for-profit organizations that help as well. But then you have informal caregivers. And a lot of people, you know, we talk a lot about the caregivers of people with dementia, super important group, but all of this applies to all different types of caregivers. My colleague on my grant is a nationwide expert on grandparenting and grandfamilies, and going both ways. So a grandparent taking care of a grandchild, or a grandchild taking care of a grandparent, the person that's in the middle and taking care of both, siblings, family. Like informal caregiving, I think if we sat down and mapped each of you in your lives and who you talk to or with, it's amazing the people that kind of pop up with that. So informal caregiving is huge, and we need them. We need informal caregivers badly. So our threats to caregiving are that same population shift with our adults getting older and needing more help, workforce shortages that we talked a minute about, changes in acute and community-based care. We're really seeing a shift from the hospital. I'm sorry for those of you that work in a hospital, but people don't need to be, the hospitals are not a good place for people, especially older adults. We want people active and in the community, right? The goal should be to keep people out of the hospital. Hospitals have their purpose and we need them, but we don't want people going and roosting there for 3 to 4 months, right? And we see that a lot in the mental health sector, by the way. It's really hard when somebody goes in for a mental health issue to get them out and back in the community safely. It's very difficult. So we're seeing a lot of change where many things that we were doing in the hospital are actually occurring in the home. So rather than taking a person to a hospital for a particular treatment, they may receive it in the home with extra support. And so caregivers oftentimes are expected to play some of these professional roles. It's okay, I'm gonna start this IV, but when it beeps, just turn it off, it'll be fine, you know? We expect a lot of caregivers, and so we have to acknowledge that we're asking them to do a lot more than if that person were in the hospital. And even then, a lot of times caregivers are in the hospital helping provide care at the bedside as well. We have to do better early detection at assessing caregivers, of figuring out what the needs are. We don't do that well. We don't have a lot of research because every family unit is different. Every caregiving dynamic is different. So it's hard to say, well, all caregivers need this. So it's important that we as providers work with caregivers to assess what their needs are, because it's different for everybody. There's also a lack of reimbursement for that, so that's really also one of the big issues. In my practice, I was able to spend as much time as I wanted with a patient. It didn't matter for my pay, and because of that, I could spend 2 hours if I needed to. Well, that's totally unrealistic for the vast majority of the medical profession, right? Because there's no reimbursement for it. If we change some of the ways that we reimburse for some of this stuff at the provider level, even in the community for nonprofits and like even our area agencies on aging, if they had some type of reimbursement, it would be helpful. And then the other one, which is really one of the bigger ones, is the failure to address the needs of diverse populations and individual caregivers. Again, every culture is different, every belief system, every value system is different for every family. For every person who's alone, finding the groups that help support that system in their value beliefs is important. And we're trying, but man, every group is different, so it makes it really hard to just throw a recipe out there for everybody. So a couple years ago, there was a lived experience panel report. So basically, the National Institute on Aging brought together some caregivers, and they tried very hard to make it a diverse group. It was a smaller group, like 30 to 40 people, but they asked them some pretty significant questions about caring for people with dementia. And so these are the things that they said. They said, you know, what do you feel like you needed that you didn't get? And this was dated, published in 2022, so it's obviously a couple years older is when they got the information, but they felt like they needed more informational support at the time of diagnosis, a greater forewarning about what would occur. And this was true, they had people with dementia in these focus groups also. Yes, ma'am.
In my experience at home health, when anybody talk to you about the diagnosis?
Exactly.
And most of the time, it's no.
Yep.
And so there's a lot of time spent, talking about the disease process and what can occur, what they can see, how they can help the person.
Absolutely.
So I'll support that 100%.
Yeah. Absolutely. And I will say part of my work and my doctoral work was working with primary care providers on behalf of caregivers. So working on caregiver assessment and providing some of that information. And a lot of the hang up, again, was, well, where do I send them? Like if I tell them that they have it and there's no cure, what do I tell them to do? And of course, this was 5-6 years ago, so we do have a lot more resources now, but that's part of the goal, right? Is not only to help the community and all of you, but to help our medical providers get some of that education on the community resources like SCAN and some of those other things that are going on. Those are super helpful, and it gives people tools to help people.
Kristi,
Yes, ma'am.
I just wanted to say, in my office on aging position, I deal with so many people who call me daily, either a husband or a wife, they're freaking out, they're so panicked because the loved one has been diagnosed, but after that point, they're freaking out because they're overwhelmed, they don't know how they're gonna take this journey. Where do you start the journey and how do you do the journey?
Yep. So those next steps are important. There's a lot of, and I appreciate you giving that information. It's a tough place to be when you don't know. Think about diabetes. Think about a child diagnosed with type 1 diabetes. And the provider says, well, he has type 1 diabetes. You're gonna need to do this, 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 and this. It's hugely overwhelming, right? Hugely overwhelming. But it's more like commonplace. And well, I'm gonna need a blood sugar kit, and the pharmacist can help me figure out needles and all that kind of stuff. And we're gonna need some diabetic education. But we don't have a lot of those things built into our current healthcare system. Yes, ma'am.
Clarify two things. One is, I'd love if you could send us the slide.
Yeah.
Because I would love to have response from the people here and see if we could come up with packets to provide them some of the answers to questions. And then the other thing I want to say is that last fall I was in France and I was on a train, and here was a mother with a child about 5 years old and had this little backpack. And the child, she did something, turns out that the child had pediatric diabetes, type 1 diabetes. And when they went to the healthcare system in France, this child was given a backpack that had everything in it. She had been fully trained. My husband said, can we help you? She was doing change outs and doing whatever. It was just amazing on the train with the backpack. And then she said, oh, that's good. She pulled out a piece of paper and has this thing, and she puts on audio, and she's got some nurse talking to her in the train, taking care of the 5-year-old. I was like, wow, this is
Yeah, that's amazing.
Hey?
And how nice is it, and would it be? And there are actually, I can send you some of the resources. There are several things built out there already. There's no sense in recreating the wheel, but the Alzheimer's Association has some great information, as well as Alzheimer's Tennessee and some others. But how great would it be to be able to start people off with a kit? Because you go home, you're overwhelmed, but then when you can't sleep at 2 a.m., maybe you pull it out, you look at a couple things, maybe in a week, maybe when the kids come for the next holiday, they pull it out. So yes, we can certainly do better. Obviously, we want to make those things culturally appropriate, provide different languages, information in different languages. And then, obviously, we've got to have more resources, even if we know it takes 4 caregivers to take care of one person who has moderate dementia, typically, if they're in the community, on some level. So there are going to be times, especially for those who are alone, who are unbefriended, or have no other resource, that they need to be placed in a skilled facility or an assisted living. In Chattanooga, we don't have places. There's waiting lists forever. So looking at different, non-traditional housing, ways that we can help give people safe housing. And then, of course, access to respite care. And then that piece of financial assistance, because, again, the slide at the for the Tennessee data, the amount of money and time, if you took the time of a caregiver and converted that to money like they were working, that is spent on caregiving, is astronomical. You know, caregivers are working their 40, 60-hour jobs and then spending 40 hours taking care of their loved ones. It's just, financial assistance would be huge for a lot of different reasons. So again, this is more of a feeling like they'd like to be less alone, less anxious at the time of diagnosis. The ability to continue daily activities. Their hope would be less sadness and boredom. Again, some of that education, like life isn't over. You can still get out and do some things, provide some of that activity. So the PLWD is persons living with dementia. There was the Public Health Center on Excellence Dementia Caregiving in Minnesota 2 years ago, I guess. A state's attorney got up he was like the attorney general for the whole state. And it was one of the Midwest states, I don't remember now which one, but he had a fall. He was about 56, 57, had a fall out of state, ended up in a hospital. Long story short, he was diagnosed with mild cognitive impairment, memory loss issues. So the doctor told him, you know, you can do whatever you want, but you can't be an attorney anymore. So over the weekend, you know, he leaves on Friday, by Monday he finds out his career's done. Well, and of course this was some time ago, but he was friends, the group that he ran with were the law enforcement officials, the judges, other attorneys, you know, they played golf, they played poker, you know, their wives did stuff together. And when he went back and said, I can't work, I have to resign, and this is my diagnosis, total silence. No more invites to golf. No more invites. His diagnosis was 6 years prior to that, and he was still up giving all the speeches talking about all these things that happened. So we have to help people understand that we can still all participate in all these things. And it doesn't matter what the diagnosis is, even if it's not dementia. It's helping people feel like they have friends who understand, they have a support system, and that there's some sort of hope and positivity in it. That helps reduce family burden and stress, and a lot of people worry about their family and the family conflict that these things will bring about. So part of your job today is thinking about how to meet those needs. So from the community level, we typically do this with, if you do any kind of leadership training or community training, we look at, you know, a needs assessment and we identify stakeholders, people like yourselves who have something invested in the game. And you come up with, based on what the community needs are, you come up with an action plan and then ways to solve the problem. And then you go back and see if your problem has actually solved once you've done it, or what the lessons learned were, the challenges or the good things. So from a community standpoint, it's really important to try and build a framework for some of that. And we can help with that. Different organizations, different universities can help with that if needed. The health department has all the tools for that as well. I know it's done on some level. But as far as caregivers and care recipients go, back to that caregiver assessment, helping the caregivers identify what their needs are, and then helping them find those resources to meet those needs. Actually making the referral instead of just saying, hey, if you'll call whoever, say, hey, you want to call them together? Or I can call them for you and have, you know, be that person that's that facilitator for them, because it's really unnerving. I don't know, I don't even like to order pizza, much less call and talk about a health problem I have with somebody I don't know, you know? Like, helping make that warm referral builds that first level of trust and relationship for that person with that resource. So it also helps with those initial, you know, making sure that person is followed up with and things like that. Again, there are a lot of different organizations that can help with formal needs assessments as well. Now, for professionals, there are a lot of different assessments that are out there in the literature. One thing that's important is interprofessional collaboration. I always say, I wish I could do everything I do with a social worker beside my side and a chaplain on the other side. To be able to practice at our highest skill set and to be able to take the experiences of your team, even your outreach and marketing people, the things that you're hearing in the community are vastly important for the organization to understand about what the needs are and what the resources are. So everybody should be part of that team and have some of that input. Of course, having directed conversations. Then there's some different tools. And then I mentioned at the beginning care mapping. I think this is really important for everyone, but especially for somebody who's really struggling or overwhelmed as either someone living with a chronic disease, dementia, or a caregiver. But there's formal tools that do this, but basically having them draw out who they interact with in a day, who their family members are, who they talk with at church, perhaps it's work colleagues. But most of the time, people can identify and kind of relieve some of that anxiety a little bit when they think about they really have a bigger support system than it seems. The trouble is asking for that help or assistance. So the next step then as facilitators is to help encourage some of those conversations among family members so that people will garner some support and accept support. There's so many people that just don't want help or feel prideful or feel bad about getting help.
Do you have a model of a care map? Do you have
But I didn't put it in my bag. I can pull one up. Good idea, I should put that in here. But basically it looks like circles. You have your person and then you've just got circles off, almost like I think about it kind of like drawing a person's family tree. Where you've got your person and then maybe you have, places that you go. So during the week, I go to church, I go to work, I go to Starbucks, where I don't really, but if I did, I don't know, the gym, my kids' sporting events. I don't know about y'all, but with boys, it turned out that my boys' baseball parents ended up being my best friends for most of my life, right? And I could call them and they'd be there in a drop of a hat. So it's people like that you don't think about, that maybe you haven't seen someone in 5 years, but they only live 2 blocks away, and they would be more than happy to drop off some groceries once a week or whatever. So helping people kind of draw out those relationships and who might be available is very helpful. And I'll get you an example for that. So for the caregiver themselves, counseling, self-care is huge. Caregivers are terrible about self-care. Relaxation training, deep breathing, that's actually one thing that makes a really big difference. And my caregivers that I see in the community are super, super busy. We're all busy, right? But they're working, they're taking care of mom, and there's just no time. And their blood pressure's through the roof. And if I can get them to take what used to be a smoke break, and every couple hours go walk outside, and for 2 minutes take some deep breaths, we can keep from having to make an adjustment in their blood pressure medicine. Deep breathing and simple techniques, especially if there's a stressful situation, are incredibly helpful. Yoga, stretching, a simple walk around the house, putting on music. There are so many programs, and I know y'all know of all these programs that help with music, but music is an incredible tool. So all these things can give people ideas, and most people have access to all that stuff, right? We've talked about all the different places of community support, caregiver support groups. I will say legal support is super important, as well as the Silver Alert. I'll talk about that in a second as we wrap up. But those are in home modifications, technology training. Those are all things we can do to help caregivers. And I know your area agency on aging has a lot of that information. I put this in here, and again, we'll get this to you, but these are kind of my favorites as far as caregiving resources. Lots of different national groups. AARP has a ton of great information. It's all free. But different places that put out lots and lots of information on everything from financial scams to disaster planning. So great resources there. And I've actually got a couple of handouts here. I think for us, to remember, we always have a call to action with caregivers. We have got to protect our caregivers. And there's a couple things that we can do advocacy-wise to help. One would be, there's really been a push for several years, and it's coming more and more to the forefront for a statewide registry and for people living with dementia. It doesn't even have to include personal information. But if we could get some accurate data on who has been diagnosed and who is providing care, it helps us write for these grants where we get this federal money where we can do programs like mine where I run around the state providing a lot of this information and support. The statewide registry would help us tremendously. It's something that a lot of people push back on for good reason in sharing information, but again, there are many states that do it without sharing actual personal information. It's a click box on diagnosis, and it's kind of a self-starter thing. Workforce we've talked about, early diagnosis we've talked about, dementia-friendly communities. All of those things we need everyone to talk about with your public officials, all the way from Mr. Mayor, who was here earlier, to the state, to the federal government.
Our sheriff is representing.
Our sheriff, yeah.
He's not
Anybody.
here, he's not people.
Anyway, social determinants of health you guys are going to be familiar with. I'm not going to spend a ton of time on them, but as I said at the very beginning, the key to everything that we've talked about today is our social determinants of health. We need people to be able to get to healthcare. We need people to get to healthy food. We need people to get to or have caregivers. So building our communities around some of these social determinants we know will help prevent social isolation and will help health outcomes too, and provide activities and quality care as well. This is Monroe County. This is the other piece of the county profile that's done by, this one was the Tennessee Commission on Aging and Disability. So this is Monroe County, the number of older adults below poverty level, they figured at 11%, 38% with a disability, 220 in the county without a vehicle at all of older adults. 4+ chronic conditions was at 41%. The numbers even going to like 6+ is huge. And then grandparents raising grandchildren, and again, another reason for something like a state registry. That number is so small. It is so small. And if we could just get more traction behind it, education behind it, and funding to help us with some of these supports would be amazing. Legal issues. We have a huge program that's done. The biggest thing that I want to reiterate here is that we talked about earlier, advanced care planning, your powers of attorney, also comes into things like elder abuse, being aware of scams and fraud and all the different things that cause people harm in the community. Has to do with capacity, people's ability to make decisions. We think a lot about persons with intellectual disabilities as well. That's a group that we kind of tag on sometimes with dementia because a lot of the needs are the same. Guardianship is important in helping people who are parents who have a child who doesn't have capacity to make decisions for themselves. Oftentimes that parent or sibling carries a huge burden if they're aging, trying to figure out who's going to help take care of their loved one. So being able to point them towards some resources to get some of that work taken care of is important. The Tennessee Alliance for Legal Services, we call it TALS. They are going to be doing free clinics with legal aid across the state coming in this next year. It's part of our grant. But they also have a helpline, and one of the things that I didn't know is they have attorneys on staff who are trained to give at least 30-minute consultation and help you get to either the resolution of your problem or to an attorney who can help through legal aid or whomever. But you can call the helpline, you can go to the website. There is, for more complicated issues, they serve a lower, lower poverty level. Then, however, a lot of their information is free to anyone. So that's a great resource, and I can also get you information on it as well, but they're going to be coming to an area near you soon. And the idea being that if we can provide some of that education, people can bring their advanced care plans, people can bring their powers of attorney or whatever they have in their lockbox and say, is this what I need or not, or their wills, whatever.
Now, is that something that nursing home patients can a lot from as well? Like, can they benefit from this? Will they go into those facilities?
Yeah, for sure. And it may be, like, you could definitely help facilitate the call to get them, but it also, you would have the avenue through like the ombudsman. They have that relationship as well. But certainly if they have capacity, somebody coming and bringing that information or having that conversation, maybe it's a question about capacity, they can certainly get that person or the healthcare staff or whomever pointed in the right direction, for sure. They're great about just entertaining questions. So, age-friendly communities, just a bit of history on that. It really started back in 1999. There was a National Academies of Math and Medicine and all this stuff. Published it's a book called To Err is Human, and the whole point was to reduce healthcare errors. So we kind of started this trend with, we want better quality care, we want to be safe when we go to the hospital. And so shortly after that, they said, well, now we realize it's not just about infection control, but we actually have to make sure that people receive timely care and efficient care, that we're paying attention to cultural appropriateness. So there was another report then, and then it went to what's called the triple aim and quadruple aim and a 5 M's. So this is what was the quadruple aim. So you know how everything builds, right? Like in 2 years, we're kind of gonna have like the 10 times aim or something. But the bottom line is, and this is really for providers in the healthcare system as a whole, we wanna make sure that outcomes are good, we're preventing illness, we're decreasing infection, we're decreasing disparities or inequity. Patients are having a good quality. They trust you, the provider, or the system. They're satisfied with their care. Costs are appropriate. We're decreasing spending and utilization. Delirium is a whole day-long thing. But provider experience, that providers are showing professionalism, that they're having joy at work, that we're decreasing provider burden. That was part of that quadruple aim. It was the first 3 bubbles, and then it brought in, well, we really need to have happy providers or none of this is gonna work at all. And then they said, well, we really need to have equity. And so they're gonna continue to add things on, but basically this is just part of building an age-friendly health system. And one of the most important things about that, I think, is for age-friendly health systems, because they have a 4 M's framework that's now a 5, and then a 5 plus a C. But if you focus on these 4 areas, what matters most, medication, mentation, and mobility, you can pretty much hit the needs of your older adult, especially even your complex cases. And so the what matters most, even though it's not showing here, is basically just defining what matters most to that person and making sure that their needs align with their treatment plan. So how many of you had coffee? Raise your hand if you had coffee. How many of you put, I don't know what's over there, but would normally put like sugar in your coffee? How many would put creamer in their coffee? How many drink hot tea instead of coffee? You love hot tea. And how many are like, oh, that's for the birds, I just need water or orange juice or whatever. So we all have our different preferences, and it comes down to our healthcare decisions as well, even inside of that family unit. You'll have different cultures with different value systems and belief systems where the whole family believes that they know better than what mama wants, right? And it's almost impossible to get mama what she wants because the children know, they know. So really working to figure out what that person's preferences are, and this is where we do the vast majority of a lot of work in education. So what matters most is making sure you understand your health status and your trajectory, just like we were talking about with that diagnosis of dementia. What's your understanding? What have you been told? What do you know? This occurs a lot with like cancers and things too. What's your understanding of your situation? What scares you about that? What are you concerned about? What's overwhelming you? Well, tell me what your values are. Are you somebody who, at this point in your life, feels like, there are different religious values, things that come into play with choices that people make about their health goals. But what are your goals, your care preferences? And getting people to start those conversations, not only with themselves and their own brain, but then to communicate to their family and their healthcare providers. It's a huge part of the advanced care planning process. So this diagram shows at the beginning, we start with really aggressive care, right? So we're great at fixing things, or we try to. Medicine, nurses especially are fixers. We can fix it. Have you tried this? Have you tried that? Doesn't matter if it's a herbal or something, but we can fix it. Well, at some point, people start moving to what we hope would be a more palliative care approach, meaning we're going for more quality of life, less aggressive care, probably less medications, but people feel better and they're able to get out. My father-in-law knows I talk about him. He often will talk to our nursing students. He's got congestive heart failure and hypertension and some other things, and one of the medicines for his heart that every piece of research will tell you that he needs makes him feel like crap. When he is on that medicine, he sits in his chair and he does not move. He gains weight, he gains fluid, and he ends up in the hospital. When he's not on that medicine, he works in his wood shop, he volunteers, he goes to church. Every single provider will put him on that medicine, and then we'll get him to take it off. And I literally have to go to every appointment with him to remind them that we're not doing that medication. And I don't do it myself, but I say, tell them about how you feel when you're on that medicine. Tell them why you're having that so much fatigue. And so it's important to think about, he's in his late 80s, and he's had a lot of issues already. And he's accepted that not being on that medicine may mean that he dies a little sooner. It may mean that his heart gets a little weaker. But he really loves to woodwork, and he really loves to go to his kids' ball games. And he'd rather do that and take that risk than to be on that medicine. But we fixers, we got to follow the plan. So at some point, we like to transition people, and we have to listen to them. We have to get them to understand and verbalize what their wishes are, and then listen to it. Yes, ma'am. Oh, time. Okay, good. Okay, so I'll get the rest of these slides to you. I have a big thing on surgery. Same concept with surgery. Not all surgeries are giving people benefit. So having those conversations. Aging in place with community safety is important with elder abuse. Disaster planning, we have programs for all that, making sure people have equipment in their house that keeps them safe. All these things keep them in their home longer. And I think at the end I had advocacy again, which we've already talked about. There's some stuff on it.
Spend a little time on this engaging community.
On the engaging communities?
Yes, because I'd really like to use that.
Yeah. So engaging communities is our, we received a grant from the Department of Health probably 2 years ago now to expand. When you're working with public health, it really helps if you're with groups of people. And the most people that you can impact with something and that have some level of support is helpful. And we know that working with faith communities is one way that we can get a lot of resources out and have a real impact on people who can help with food and things like that. So we have been traveling the state working with different faith and religious communities. Tennessee especially has over 51% of people attend services weekly at some type of organization. And they report that religion, 85% say religion is important in our life. Doesn't matter what kind of religion it is, but they have some sort of religious affiliation. So because of that, we are able to leverage the trust that people have in their leaders, as well as the experiences. Religious communities and churches are really great at things like disaster response, and they have experience with going in the community. So our hope is that we can give people, organizations, the resources that they can help those within their congregation, but then eventually take that out to their neighborhood. So this is really just the first start of getting information on the care of older adults across the board to different communities. And we offer training and topics on, really for any audience, on dementia education, caregiving, transitions in care, so like that home and community care-based services versus assisted living versus PACE versus skilled nursing. We have legal experts, mental health experts, We do a disaster preparedness packing party thing. We're coming out in September with a module with different information on elder abuse and fraud, and then also livable communities and accessing resources. So I have a lot of information digitally that has lists of resources for all of these different things, most of them on the state and national level, but we collect different information when we go to different counties as well. We also have a toolkit for faith leaders or volunteers within a church who say, well, I'm willing to organize some of this kind of stuff. We can get them a full toolkit that has lots of different education and resources to get them started. The church or the congregation or religious organization is just like your community. Everybody has different needs. So some people may say, well, we're really struggling with fraud. Like literally everybody in the congregation is having trouble with fraud. Versus some others say, we have a really strong group of people with dementia and caregivers that need help. We use partners from the Alzheimer's Association and Alzheimer's Tennessee, Honoring Choices Tennessee, which does advanced care planning. I mentioned TALS, mental health, and then we have Heart, Tones, and Alter Dementia, who work specifically with African American churches on advanced care planning and dementia-friendly worship and training faith leaders how to care for people in their congregation with dementia. And then, of course, our primary partner is the Department of Health. Workforce and advocacy, which we've covered. So we want people to know there's hope, right? If we can get rid of some of the stigma, some of this fear, not only with dementia, but with all chronic diseases. Aging does not have to be a bad thing. Aging is great. My mom is living her best life, but you know, she needs little things here and there, but she still wakeboards and does all these things. We don't have to lose hope with a particular diagnosis. Things you can do for yourself that are across the board for any disease are your eating healthy, sleeping well, getting your health care prevention stuff done, exercising, socializing, and your legal activities. And then things you can do for others are raise awareness, advocate, participate in research, and then of course support caregivers. And I think that's the last one. Yeah. This one is my information. I have some cards. I do have some handouts. I'm not sure if I have enough, so if you're with the same organization, if you'll share. But it has our contact information on here too. I have a project manager that helps us, so we can get information out. We can come schedule an event or host, or I'm happy just to talk about things that are going on in the community. If you have a question or not sure how to answer a question that somebody has, I'm happy to help with that too. I field phone calls all the time. So thank you all. I know that was long, but hopefully
Straight off question for Kristi, right off.
I have a comment, more than a question.
yes.
So regarding the diagnosis of dementia in general, the diagnosis is a pure today, still a pure clinical diagnosis, meaning that there is not a specific test, a specific blood test that we do to say somebody has dementia. It doesn't have to be a neurologist making the diagnosis. Geriatricians, nurse practitioners that are trained in gerontology, PAs that are trained in gerontology, and even family medicine doctors, internal medicine doctors that are trained can make a diagnosis, have a classification, start treatment, and follow up on treatment. So this is something that is people should know, because there is always the conception that the diagnosis of dementia has to come from a neurologist. And actually, neurologists don't like to see much dementia patients because that's not where they get their excitement. So I wanted to make sure that people knew that. I know many of you guys know that, but not everybody does. So bottom line, diagnosis is clinical, and any trained professional can make the diagnosis and start and follow the treatment.
Absolutely.
Thank you for
That's
great presentation.
That's a great point. Social workers are great at cognitive testing and all that stuff too, but more importantly, even if somebody doesn't want to go through that process, you can start, or if you have a suspicion, getting them plugged into community resources or give them tips on how they can manage whatever's going on. So thank you for that.
I'm hoping that this is the beginning of a relationship with Kristi and her team. That there are many things, as you can see on her list, that we could not plumb the depth and breadth of her brain and experience today. But I wanted you guys to have a sense of what all she could do. so that you can contact her, and then different organizations can bring in different aspects of this engaging communities. What I'm handing you all is little yellow pieces of paper. We have really wonderful door prizes, but we have no way to pick them. So you have to put your name and your phone number on that, and we will be doing door prizes for sure. And similarly, if you have a question that you don't think you've had the time to ask Kristi, I would really like you to write it on paper. We are going to put we've got your names and email them, and we're going to start a little group that we can communicate with each other. We will put the questions and the answers on that list, so this will be an ongoing experience, that you look around the room and all of you are in somewhat, not the same place, but similar places. You're trying to work with elderly people with not enough staff, not enough money, and you're exhausted. Did I leave some factor out? Maybe you haven't had breakfast either, but we're trying to make certain that you feel supported. Now, I made a push, because I knew what was on Kristi's slide. I made her do engaging communities because it's a great segue to our next speaker, and I just thought that was a great way to think. Does anybody need a moment to stand up and stretch?